You ready to go?
Good afternoon and welcome everybody to Basic Food Care in Diabetes, brought to you by Gintervene's Health Foundation. Thank you all for joining. We are also streaming live on Facebook, so if you still have time to invite people if they would like to watch on Facebook and join the program. We're just going to take a short address from the founder of Gintervene's Health Foundation, Dr. Andrew Agun. Over to you.
Thank you very much, Flora. I welcome all of you on behalf of the Board of Trustees of Intervenes Health Foundation, our facilitators and supporters. Um, Intervenes Health Foundation was established in 2018, and basically it's a charity, and basically a social philanthropic charity, and with a bias to intervention in healthcare, especially in Nigeria. And we hit the ground running in 2018 by organizing an instruction in basic food care. We're lucky to have had a podiatrist based in the UK who raised money, which is Fumi Ogunyoye, who was able to go to Lagos, and we were able to train 12 nurses and 5 community pharmacists in basic food care. And some of these nurses are now, and pharmacists are now looking after the feet of diabetic patients and people living with diabetes. There have been a lot of support, a lot of unbelievable support from different individuals to support our projects. We've not had a lot of resources, but a few people have dipped their hand in their pockets to support our projects. But we've been facilitated by amazing people, and a lot of people have given a lot of their private time and energy towards sustaining the project. Every single project that we undertake is based on money raised. We don't get any sponsorship, but we hope this will be an opportunity for a lot of you with contacts to signpost us to those that will sponsor our programs. We do hope eventually, podiatry and food care, especially in diabetes, is almost lacking in Nigeria. No university offers it as a course. But not only that, apart from a few patches in Lagos and Abuja, and a few of those we trained in Benin, there's almost no food care or podiatry in Nigeria. And we hope that with things like this and with more people getting involved, it will spread, because we know that if people look after their feet, they will avoid amputation. And as Professor Fasamade, who has been one of our facilitators, will be telling you later, a lot of those that get amputated almost are disenfranchised. They lose their livelihood, they lose their life, and they can't fend for themselves. The panel is full of a lot of good speakers, and I hope it's going to be a session where everybody will be able to take something up. I won't keep you too much, but I hope by participating, you will also be able to spread the message, and that food care and proper control of diabetes will become the norm rather than a thing that is rare. Thank you very much for listening. We have some very good speakers. I'll let you know that there have been some um, reception problems. So as a backup, we've recorded some of our speakers so that if we do find as we go along, they are not able to, we are not, there are reception problems, we'll play the videos for you. Thank you very much for listening. There are some very good speakers, and we hope you'll be able to stay all through the program. I'm going to now introduce you to Professor Femi Fasamade, who is a professor of medicine at Lagos University Teaching Hospital and also a consultant pharmacist. While I'm still speaking, I know John Isagbedo, our project manager, is going to give a vote of thanks but I'm going to acknowledge the amount of effort himself and Flora, Ms. Coker, and all those on the panel have put into putting the program together. A lot of the times when we go on these Zoom meetings, we just attend them, but it's been an interesting experience about what it takes to put it together. So I hope you participate well, and I hope you take something out of it. There will be questions after each speaker, so please do avail of yourself. Now, I will hand over to Professor Femi Fasemade to give a little talk. Thank you very much. Professor Femi Fasemade, you are on.
Good afternoon. Thank you very much for having me on this panel. Dr. Andrew Agbo, my good friend, and Flora, our moderator, and all the very, very wonderful people. I can see John somewhere. I can see Ms. Ogunyoye in another place, and so many other people here. So I'm glad to be with you all, and I will just speak for a few minutes because we know that there are a large group of people who are listening to us, and there are several people who also will be talking. So diabetic foot ulcers worldwide are a very, very big problem. Many people do not realize that a person that has diabetes has several times higher risk of having a lower extremity amputation than the other parts of the population. To give you an idea of how frequent the problem is, when you look at people who have had amputations worldwide, more than 60% of them are usually due to diabetes. So when you see somebody walking on the streets of Lagos or London, and you see the person with one leg, you can almost bet, and you will win the bet, that the person has diabetes, and that led to amputation. How does diabetes lead to amputation? Because amputation is the end result. Is the end result when it is not prevented or when it is poorly treated. People that have diabetes usually have some problems with their extremities. And the part of the body that is furthest away from the center, meaning from the brain or from the heart, are the feet. And that is the reason why most of the problems that they do have are in the feet. Person with diabetes, because of the high blood sugar, because of the high cholesterol, both of which are common in diabetes, and because of hypertension, the vessels get damaged. And the vessels are just like tubes, or they are just like pipes which convey blood from the heart to the extremities and back. In a person that has diabetes, these pipes get rusty or they get blocked, which is what we call peripheral arterial disease. And then also the nerve supply to the feet also becomes affected, which is what we call peripheral neuropathy. So the nerves are supplying the legs of the person with diabetes get affected, and then the person cannot feel properly. So you find that many of our patients that have diabetes will complain of either numbness of the feet, or peppery sensation in the feet, or itching, or things that are like needles and pins in the feet. Some patients will tell you that they feel as if they are walking on cotton wool. All of these sensations are due to diabetes. All of these sensations are due to nerve problems. Other patients will tell you that when they walk after a short distance, that is evidence that the blood supply. So a person with diabetes usually eventually it leads to a situation whereby the leg becomes at risk of having ulcers, and then eventually
Okay, seems Professor Fasamade's network has frozen. We'll give him a few minutes to come back. on. In the meantime, oh, he's back. Here we go. Just waiting for him
Yeah,
to.
sorry, the network went off. So as I was saying earlier, before I went off, I quickly speed before it goes off again. When we have diabetes, it affects both the arteries and it affects the nerves. And when these two are affected, it leads to either wounds, which we call ulcers, or it may lead to decay, which we call gangrene. When either of these occur, a patient develops a sore on the foot that fails to heal. Most of these sores, the patients carry them about. Some of them become very, very foul smelling and may lead to life-threatening complications, include sepsis. Because of this, eventually, and will require to have surgery. So the purpose for our being here today is to prevent this bad sequence of events, meaning preventing ulcers or preventing amputations. And the simple ways to do this are proper being very vigilant. Check your feet on a regular basis to make sure that there is no wound, there is no discoloration, there is no athlete's foot. And if you do this, you can prolong the feet, the life of your feet and the health of your feet. So this is what I will just have to say. In the meantime, I'm sure we'll take questions later on, and then probably we can discuss as the program goes on. So with this, I will just leave because I think I've already spent my 3 to 5 minutes. Thank you.
Thank you very much, Professor Fasomade, for that introduction. And that leads us nicely to our first speaker. She is a registered nurse and midwife, and she's also a non-surgical foot care practitioner. And her name is Miss Oluyemisi Oluwashola. So she will be talking to us about the importance of foot examination. So I'm just going to get her to unmute herself, and then we'll share her slides, and then we'll take it from there. Yeah, Missy, it's over to you.
Okay.
Would you like me to share the slides now?
Yes.
Okay. So just give me 1 second.
No, it's not Galazi. I can't see you.
Okay.
All right. Good afternoon, everyone. My name is Oluyemisi Oluwashola from Doing Healthcare Service here in Nigeria, Oyo State. I'm a registered nurse midwife, and I have passion for looking after people with diabetes. So when I was in the UK, I went for foot care practitioner training at BSY College for some months, and I did my practical at Eastbourne in London. And so far, so good. I've worked with Mission Care as a foot care practitioner, and I've been independent foot care practitioner for a while. And I've been looking after people's streets here in Nigeria also. I've had experience here in Nigeria. Because I've worked basically at nursing home when I was in UK, so I've got myself involved with looking after their feet. So basically, I just want to define diabetes just briefly. As we all know that diabetes is a metabolic condition that allows the glucose level in the body to be high. So when there's high glucose level in the blood system, it can lead to so many problems if care is not taken. So as we all know, our feet, let's say our feet is at the lowest part of our body anatomically. It helps us to do so many things. Our foot, as we all know, help us to do so many activities like jogging, dancing, walking. It also helps us to move around to do daily activities. So I'm going to slide 2 now. So how do we check our feet? We check our feet daily, in the morning and in the night. We check it after we come back from work and after we're going back to bed, after our daily activities. What do we look for in our feet? We check our toes. We check the toes for corns. We check the toes for corns. Corns are those shining off on the top of we visit this section when we are checking out. We check for bunions. Bunions are those ones at the big toe. When you notice that your toe is bending towards the other toes, those are bunions. Then sometimes blisters, we can see blisters at where there is friction on our fruits. Other thing we can notice is the tinea pedis. If you check in between your toes, you can see tinea pedis. That is on slide 4. This tinea pedis is that whitish particles that we see in between the toes. It can be smelling, it smells a lot, and it can be painful and pepperish when you notice that, and which is not good if care is not taken. It can lead to a very big foot ulcer. Other things we can notice when checking our feet daily is you can, callus. Callus are those yellowish whitish watches at the heel of the toes. Hello? Calluses are those yellowish that we've seen on the heels of our fruits. They can lead to a very big foot ulcer if care is not taken. Check for bunions. Other things to check for is, we can check for sensitivity. You can ask a member of your family to help you to do that if you are not able to do it. How do you check for sensitivity? You check for numbness by asking someone to give you a tickle at the sole of your feet. Other things we can do is that when you close your eyes, you can gently tap your toes and see, maybe you can have the feelings. Other things we can do is that you can use cotton bud, the ordinary cotton bud we use in the market. You can use that one to run through in between your planters to see whether you can have any feelings. If you have any feelings, then that is good. If you don't have any feelings, then you have to report that to the podiatrist or to your doctor or to any healthcare provider that is around you. Again, that leads us to protecting our feet. How do we protect our feet? By wearing appropriate footwears. You know, the Diabetics UK advise us to wear leather shoe, but if we cannot afford leather shoe because of the financial situation, you can buy any comfortable shoe, but make sure you clean them every day. And we make sure that the inside of the sole is not wet. And we should try and avoid wearing tights, you know, the pointed feet shoes. They are not good because they can cause friction in between your toes and the shoes. So protecting our feet is good with appropriate footwear. Other things we can do to protect our feet is we should avoid, especially men that wears a lot of socks, we should try and avoid wetness. You know, when you perspire a lot, then there's tendency for your shoes, the socks to get wet if you don't take out your feet from your shoes throughout the day when you are in the office. So we should try and avoid wetness. That one can lead to fungal infection. We should try, this one goes to women. Women should try and avoid wearing high heels. When you wear high heels and you fall off from the shoe, it can lead to a very big foot ulcer if care is not taken. Other thing we can do is, I want to talk about what to avoid now. What to avoid when caring for our feet. We should try and cut our nails straight. Then we should try and avoid using razor blades. I don't know if you can see me. You can use the nail cutter. That one is the one advisable by Diabetics UK to use, because when you use the nail cutter, you won't be able to cut the skin of your nails. So use nail cutter. Otherwise, if we have the money, you can visit the podiatrist or the chiropodist wherever you are in the world. Then again, we should avoid it because some people they want to try and cut the calluses because it's not good thing. So you should try and avoid using razor blade to cut the callus at the soles of your feet. Instead of doing that, go and visit the foot practitioner, or otherwise, when you are at home, I will advise you to soak your feet inside warm water, add a little bit of salt in it, and use a gentle scrub to scrub it daily. If we do that daily, then there won't be a lot of buildup of calluses on our foot. So another thing we should do, we should avoid wearing tight fitted shoes. Then again, this is common in Nigeria or anywhere. We should avoid all these clumsy environments. When you leave your stool somewhere, your stove somewhere, your gas cooker everywhere, the whole place is littered, and you just enter without looking on the floor, you can knock your toes because of the type of slippers we wear in Nigeria. We don't wear covered shoes a lot. So we should avoid clumsy environment to prevent accidental injury to our toes. I would like to advise us on some home remedies that we can do to protect our feet. So washing our feet daily, we should pay attention to in between the toes and the heels. In between the toes can lead, if we don't look after it, we can have fungal infection, that is the Diabetics, the cornea that we call it in Nigeria. Then the heels, we need to wash it daily. Then our socks, especially the men needs to wash their socks daily to prevent fungal infection. Then there are so many foot moisturizer, like the Soft Fields in the UK. That one has milk and honey. That one can be used. Here in Nigeria, where we don't have some foot cream, you can use Vapor Rub. Vapor Rub is good for the feet. You can apply it to the heels. That one can prevent cracks. Otherwise, when you go to the pharmacy, you can ask your pharmacist that you need a foot cream. They will give you the one that is available in your environment. So what do we report to the podiatrist when you notice that some symptoms? Like if you have cramps at the calves of your foot, at the legs, having cramps is a bad sign. You need to report to the podiatrist. Swollen feet is bad. You need to report that one to the podiatrist too. Then sometimes people have restless legs at night. They do complain when they come to the clinic that they have a restless leg in the night. You need to report that one to the podiatrist. Sometimes you might have open wound. You don't have to treat your open wound by yourself. You need to report to the doctor so that they can use appropriate measure to do it. So that is the little advice I can give for now. Anyway, in summary, appropriate footwear is the best. Maintaining good glycemic control, that is taking our diabetic drug daily, eating good food, balanced diet with a lot of vegetables, and we should report anything that is not good, that is any changes in our food, in our body, even especially in our eyes. We should report it to the doctor on time so as to prevent complication arising. Thank you.
Thank you very much for that. That was very informative. I'm just going to stop sharing the screen now. So if you have any questions, please could you type them in the chat and then we can put it to our speaker, Yemisi. If there are any questions, or even for Professor Fasimade, if there's any questions, we can take some questions now. Okay. Any comments from even the health professionals? Any questions? Yeah, let me see. We're getting some good comments here. Thank you to the presenter for a beautiful presentation, for both presenters and for Professor as well. That's fantastic. Thank you. But if there are no questions, then we'll move on to the second speaker. Okay, let's do that then. So, okay, we have someone raising their hand. Sister Jai. Okay, could you ask your question, please? I've asked you to unmute so you can ask your question.
Okay. My questions are very many.
Do you have
Just one question.
Yes, please.
My legs presently are swollen, and the latest report on the biopsy done shows it is a psoriasis. And during the course of taking series of drugs, which include metformin, 500 times 2 daily, the feet is not going down, quickly, and the toes have this canyon, tendency and ugly side. This diabetes thing, I was not originally a diabetic. I was going for something else, but suddenly started observing some, ugly looks on my feet, which made me to be referred to Harvey Road Yaba for continuous treatment, which now discovered that I had psoriasis. I'm still undergoing the treatment, but I will want to have more clarification on how to take care of my feet in the course of taking care of the psoriasis. That feet is ugly for me to be carrying about. Thank you.
Okay, I'll just ask if Professor Fasamade was to take that, or Yemisi or Dr. Agum, just quickly.
Okay, doctor, the patient who just finished talking, she was complaining about two different things, or three. One of them is leg swelling. One of them is psoriasis. And the third one, which I got from what was saying, is that she has kanyu. Kanyu in Yoruba is Yoruba for tinea pedis. So all the three of them are for three different specialties. For instance, the leg swelling might be due to problems with the heart or with the kidneys. So she will need to see her doctor. The tinea pedis, which is what is calling kanyu, she will need to see a dermatologist or use some antifungals for that. And then the last one, which is the psoriasis, is also something to be handled by the dermatologist. So generally speaking, she needs to see about 2 or 3 specialists, a diabetologist, a dermatologist, and maybe a cardiologist.
Okay,
But
thank you very much.
She can send me an email to ofasamadi@gmail.com.
Okay. Thank you very much for that, Professor Fasamade. We'll put the email in the chat box as well. Professor Fasamade, could you put that in the chat box for us so that everybody can have that? Okay, so we have another question from Dele. Do we have any data on the prevalence of diabetic foot disease in Nigeria? This question is for Professor Fasamade.
Yes, we do have data for diabetes amputations, but the problem with Nigeria is that once you have a faulty denominator, you cannot get the accurate figures. Nobody knows the population of Nigerians till today. Online, I think the latest I saw was 206 million. Also, the number of people that have diabetes in Nigeria, according to the IDF, is just between 1.7 to 2 million. Likewise, we are not sure. Some people say it's much higher than that number. But one thing we are sure of is that one of the commonest complications is diabetes foot ulcers. And the data from all the hospitals that I've visited or checked shows that the commonest cause of amputation is diabetes. Amputation of the leg is diabetes. So those are the data that we are very sure of.
Okay, thank you very much. I hope that answers the question to the person who posed it. Okay, if there are no more questions now, we're going to go to our second presenter today. Her name is Mrs. Fumi Ogunyoye. She's a podiatrist, and she undertakes general podiatry care, diabetes foot care, and foot health training. And she's actually going to give us a practical demonstration of foot examination. Over to you, Fumi.
Good afternoon, everyone. Thank you for the introduction, Flora, and thank you for the previous speakers, very useful. I hope that this basic foot examination will assist. and also shed some light on what has been discussed already. Yes, we've acknowledged we have some professionals on board, as well as some lay people, as we heard from the lady earlier. So what I'm going to hope to do is to address the general issues in a way that will deal with both professionals and individuals. So the first thing is, when we are dealing with a foot examination, we have to start with the big picture. And as a professional, that means when someone is coming in to sit into the examination chair, we have to be observant. So obviously we look at how they're walking. So that is something that's second nature, for professionals. It's just something you notice. So obviously, if you notice maybe some sort of unusual gait pattern, as in the way they're walking, maybe with a limp, or as though there's something going on in the lower limbs, we will ask questions even before or during, at some point during the consultation. Or why are you walking like this? Sometimes even the patients may forget to tell you the reason why they're walking a certain way. Sometimes they might not even know because they're so used to it. So that is just something, as a starting point. The next thing, obviously, is they come in and they take off their footwear. Footwear, as Professor mentioned earlier, and Yemisi also mentioned earlier, is extremely important, because obviously I can only speak from the perspective of working in the UK. I've been working with diabetic feet for over 27 years, and with a lot of the problems we see in the hospitals, many of them are related to footwear. This is from my experience. I'm not talking of statistics, so the statistics may be different, but this is what I see. So footwear is extremely important. And what I'm going to do is just give a simple examination of the footwear, of what we hope to do. This is what I tend to do generally when I'm doing a diabetic foot assessment. With gloves on, I would run my hands through the shoes just to check, because I have had in the past experience of seeing pins in people's shoes. I have had experience in the past of seeing someone with a diabetic foot ulcer where there was a pin inside. They were not aware because of neuropathy. So that's why the importance of footwear, very, very, very important, extremely important. So I want to emphasize that point. Also, when we look at the footwear, we also need to look on the back, because just looking on the inside is good, but also the back is very useful in giving us ideas sometimes where people are overloading. So for example, when it comes to diabetics, you may have a diabetic that's overloading on a particular part of their foot, on the ball of the foot. They have maybe a history of ulceration, or it might deem them at risk of ulceration because of the way they're walking. So obviously, when we see things like that, we have to think ahead, because obviously you're trying to prevent an ulcer. So with someone that, say, for example, is wearing or putting a lot of pressure, say, for example, under the big toe, for example, we might suggest they get an insole of some sort to help with cushioning, helping the shock absorption, and that will also help hopefully prevent a potential ulcer. So these are examples of footwear. This is one here, and this obviously, as we all know, is a trainer. These are very, very excellent things. Believe me, if you know how many patients have changed from wearing inappropriate shoes to trainers, and their ulcers, disappear, or their lesions disappear, or they're more comfortable, their lesions heal quicker. It's really, really, interesting that footwear does a lot. So footwear, is very, very important. I've also got an example here of inappropriate footwear for us ladies, and people that do wear inappropriate footwear. When we talk about footwear, depending obviously on the climate, depending on what people's fashion sense is, some people tend to prefer open-toe shoes. Now, as Yemisi mentioned earlier, open-toe shoes are not the greatest things for diabetics. So this is the advice we tend to give, is avoid wearing open-toe shoes, because it basically leaves your feet at risk of damage. So say, for example, they're walking about, something drops from somewhere, which happens. A lot of people I see sometimes is at work, something dropped. damage their toe and, etc., etc. So obviously it's leaving this area at risk, so we advise to avoid wearing open toe shoes. And also, we also have open back shoes. Obviously, we have to be practical because in some climates, people will prefer open toe, open back, sandals, slippers, etc., etc. So if people are taking that risk, which sometimes may not be avoidable, if that is what, the budget allows, or etc., etc., they need to be aware of the risks they're taking. So obviously people like that, if they say, look, this is what I have to wear, or this is what I can afford, it be a matter of emphasizing then for them to examine their feet on a daily basis, because that's even more important. So if at the end of the day they can't wear a closed toe, make sure you check your feet every single day. And I will get onto that now. So when it comes to checking the feet, what we need to do is, sorry, just 1 second, please. So when it comes to examining the feet, we now have them sitting in the chair. I usually like to start, there's no order in doing this, obviously, everyone is, has the way they do things, but Professor mentioned earlier about temperature changes, and I believe the MEC also mentioned it. So temperature changes are really, really important. In extreme cases, and these are cases that clinicians will probably be aware of. I've had about 3 or 4 instances where I've had to refer people directly to vascular. When they've come in, you feel a huge change in temperature. So usually we start from the top and work our way down. So obviously if you feel, from a clinical perspective, and also maybe from the symptoms being given, and sometimes maybe from the examinations you've done and tests you've done, there's a need to refer someone to vascular, then of course, that's something that will need to be done. But obviously document if there are any prominent temperature changes. Next thing to do is to look at the feet, obviously. And looking at the feet takes, we have to take so many things into perspective. So obviously, I know, yes, 5 toes on each foot, yes. We need to do everything carefully. We check each toe. We look at each toe. We check in between each toe. So this is a standard thing that we do. And this is something I do with diabetics and non-diabetics. I do it with everybody. We look in between the toes just to check to see what is there. Hopefully, we don't want to find anything there. In some cases, we might find a bit of moisture there, a bit of athlete's foot. We may find a corn, we may find hard skin. We may find an ulcer. So we may find various things there, which, we hopefully will address and will signpost, the person to what to do to prevent this becoming a greater problem. So obviously we'll check in between the toes, we check the condition of the skin, we check the quality of the skin. So is the skin well hydrated? Is it very dry? We heard from the lady earlier, whereby she mentioned that, she had psoriasis. So sometimes you may get a presentation of a skin condition that may look dry and could be something else. So obviously it's good to find out if, there are underlying conditions. But in cases where you find the skin is dry, which is, sometimes a bit common, it's good to address that, as my colleague mentioned earlier, give advice about moisturizing, etc. So when we examine the foot, what I always do is sweep around the heel. That's just a standard thing, because again, you'll be surprised what you may find there. With some people, it might just be a little fissure. With some people, it's a bit of dryness. With some people, it's actually bleeding as well. In many cases, it's all intact, but the key thing is we want to assess, is it intact? Is there any break? Is there any risk of breaking? Is there any, potential from what we see with the way this person's, footwear is looking, their habits, etc., etc. So looking at the skin, we address if there's any corns, which have been spoken about earlier, any lesions, hard skin, any warts, that sort of thing. If there are, obviously we document them. Then again, we have to address them by advising as to what to do and how to avoid, problems. One thing we also check is capillary refill time. So with that, we press the toes, hold tight, and the usual refill time is about 2 seconds. This can be an indication of circulatory issues. It could be, so it's something to bear in mind if it's delayed, extremely delayed. And then the other thing is to look at whether there are deformities, as my friend mentioned earlier. Deformities, as she said, corns, bunions, as we can see from this foot, there are no deformities there. But, you see these deformities. For example, a bunion can cause a risk of ulceration to be higher in a diabetic, because if they have a bunion, then they are wearing inappropriate shoes, which sometimes is the case. They wear the shoes they had before they had the bunion, or they wear the shoes they want to be in, So what we usually do, and what I tend to do with a lot of my patients, especially when they're wearing inappropriate shoes, is it's a 2-second thing. I ask them to stand on the floor. When they are weight bearing, I draw around their foot with a pencil. I show them their shoe, which might be this narrow, and then I show them their foot, and I say, look, how is this going to fit into here? Something has to happen, So it's just to show, and hopefully that will sell the idea of changing footwear, because the changing of footwear can be a very difficult thing for some people, especially if maybe work-wise, if they're fashion conscious, if this is what they've done all their lives, and as we get older, the feet are different. So the next thing I will talk about is when we say deformities. I have something hopefully we'll share maybe later on. Some people have like some deformities. This is not very common, but it's something called the Charcot foot. And that is where you may get some degeneration of the joints that is also associated with nerve problems with diabetics. And some people get ulcers that could be related to that. So if a person has that sort of a problem, obviously that's something that needs to be dealt with, by a multidisciplinary team in the hospital. So going back to the examination, we look at the feet, no corns, check the heels, check everything. We look at the nails, because you'll be very surprised that sometimes nails can actually cause problems in diabetics, especially with big toenails. Some people may have an ingrowing toenail. If that's the case, then again, we have to give appropriate advice as to how to cut the nails, what to do. If they have an infection, they may need some antibiotics. They might need to see the doctor or the pharmacist. And then, we also check sensation. So it's been mentioned earlier again by the previous 2 speakers about sensation. Now, as the professionals on this platform understand, with diabetes, sometimes can come neuropathy, peripheral neuropathy. And neuropathy is to do with the affecting of the blood vessels that supply the nerves, because the nerves are very tiny. And diabetes, as Professor explained, damages sometimes the blood vessels. So sometimes what happens is people may lose sensation in their feet. And if that happens, obviously it's not something we can stop, but it's something we can monitor and something we can advise and something we can grade, because obviously people's risk factors vary. Diabetics usually are graded according to the risk factor. You may have a diabetic where the blood sugar is well controlled. They've been diabetic for many years. You see them, you do the diabetic foot check. They have no lesions. Their pulses are good. They have good sensation. They're wearing good shoes. They're following the right advice. Usually there's nothing more to do, So if we have a diabetic that, say, for example, has poor feeling in their feet, so we will use a monofilament to check. Ask them, can you feel me touching your toes? Can you feel that? So they feel where the touch is, and where they don't feel it, we document it. So say, for example, we find this person cannot feel anything on their heels because we are doing that and they can't feel it. We know to advise them appropriately, because if they happen to have an accident of trauma of some sort where they step on a nail or a pain or something, it's very likely they won't feel that pain going through their foot. So someone that has neuropathy is a higher risk. So we have to give them that extra advice and emphasis that, look, you have to check your feet every day. Look at your feet every day, put your hand and rub your feet every day, make sure there's nothing there. Okay, so that is the monofilament. If you don't have a monofilament, as Yemisi mentioned, you can use cotton wool to get a rough idea, of how to do things. So the next thing is, I'm not going to do this, but some people test vibration, which is a much more detailed test, if you want to do that. And some people also check the reflexes. So that I'm not going to do, but that's something that some people also do. So pulses are usually useful to check because you can do that manually. And so what I'm doing here is I'm just going to palpate the dorsalis pedis pulses here, which I can feel. they're strong and regular, and posterior tibialis here, which I can also feel. So what I'm going to do now is just use my Doppler. I hope that you'll be able to hear the sounds, but I'm just going to use my Doppler to help me confirm what it is that I felt manually. Okay, I just felt it there. Interesting, because I got the spot on when we were checking earlier, but I'll try one more time and see. We should get it there. It's quite prominent. Right. Well, usually it's easily found. Let's try the posterior tibialis. Okay, I don't know if you can hear that. Okay, so that's the posterior tibialis there. Okay. So that's the posterior tibialis. I'll try if we can see this dorsalis pedis one more time. I'll do this very quickly if we can find it. Well, I don't know where it's gone, but it was there earlier. So let's leave that for now. The key issue here is check pulses. If you have a Doppler, Dopplers are very good at confirming what you hear. Now, when you're a practitioner, obviously there are different qualities of sounds that you hear. There's triphasic, monophasic, and biphasic. My colleague that's doing the next talk on vascular is going to give some information about signposting, where you can find some more information about the Doppler and the sounds, etc., etc. And you're very welcome to ask us questions as well. So what we're going to do now is just round up. The final thing I want to mention, though, is when we do this diabetic foot check, is not to forget, like I said, the whole person we're dealing with. So one thing I always do with all my patients is to ask them, are you having your eyes checked? Because again, the blood vessels in the eyes are very tiny and can be affected in some cases. It's always good for them to have an optician's appointment minimum of once a year. So this is something we always do, is encourage them, have your eyes checked. And also, I always ask in terms of, just to make sure there's someone monitoring their management of the diabetes, their blood sugar, etc., etc. Are you with a nurse? Are you with a pharmacist? Is there someone taking care of you? Just to be sure of that. And obviously to ask them as well if they have any questions, because sometimes they might want advice about that dietitian. We signpost them. They might have issues to do with, dermatology, as someone mentioned earlier. We signpost people for all that. So the key thing here is encourage them to have a routine. Routine is look at your feet once a day. Check your feet, look underneath. If you can't do it yourself, get someone else to just have a quick look. Any problems, like my colleague said earlier, get it dealt with, go to the right channels, and be signposted to the right places. So that is all I have to say. I mean, the other thing I'll mention about the cons and calluses, which my colleague already touched on, was gentle filing, using a file on the hard skin or maybe a pumice stone. We advise against use of razors because they're not sterile equipment. You don't know what you're doing. If you're doing this as a layperson, it's pretty dangerous. If a person has neuropathy, they might be doing more than they need to do. So it's always best to get a health professional's guidance or direction, you know, in doing anything like this. So I believe that that is all I need to say. If there's anything I've missed out, which I probably have, feel free to ask questions, and you know, we'll be more than happy to assist. Thank you very much.
Fantastic. Fantastic. Thank you so much, Fumi. If anyone has any questions, they can raise their hand or type it in the chat box. Any questions for Fumi? People would like the recording. They said this is fantastic. That's some comments in the chat box. Yes, the recording should be uploaded on YouTube, hopefully within a week. So you can rewatch it there if you need to. Okay. Any questions, anybody? Can't see anyone raising their hands. Anyone else see anyone? See, for me, your explanation was so perfect that nobody's got questions. You probably answered all of them in your presentation.
Well, we're happy to have any more questions. Not
Yes.
later on, if at all. Yeah.
Okay, we have somebody. We have another Kemi who wants to ask a question. So Kemi, I've asked you to unmute. So unmute yourself and ask your question.
Thank you so very much for that very lovely presentation. I just want to ask if you mentioned bunion and corn and onion and is it calluses or whatever? What would you advise with someone who's got diabetes? What would you advise them to do, especially? Is it just like filing or, you know, dry skin, especially like dry skin and, you know, which is bunion that you said could develop into ulcer? So before that happens, what do you really advise them to do apart from really hydrating the feet and maybe, you know, making it, you know, putting creams and things like that? What do you advise them to do? And is it then one other thing that I know is that they need to keep their feet very dry as well. Like some of our patients that we have, you know, when they have their bath, they don't actually clean in between the toes very well, and a moist feet too. It could be a risk factor. So what would you say about dry skin, bunion, and corn? How do you advise diabetics to manage that before it develops into anything?
Right. Okay. So thank you. There are a few questions in there. You mentioned bunions. Now, a bunion does not have to be a problem. A bunion, in some cases, people come because they don't like the way it looks. Okay. Now, when you have a bunion, that means the person has to change their footwear, and they have to ensure that they get footwear that's appropriate for that bunion. We see a lot of people with bunions and they have no problems. The people that tend to have problems that I've seen over the many years I've been doing feet are the people that wear the tight shoes. They get a bit of friction, they get a blister, they get a bit of inflammation, then hard skin, then a corn, then maybe breakdown. And the only reason why they're having that is because they're not changing their footwear. What I have done over the past many years, even in the last couple of months, I ask my patients for permission, especially the elder ones that wear slippers. Do you mind if I put a hole in your slipper? Usually they say they don't mind. These are some people that are maybe, they're not going out so much. We put a hole in the slipper, the problem disappears. The bunion is still there, but there's no corn, you know, no ulcer, because it's really caused by pressure. So a bunion on itself is not a risk factor to having any problems. It's what you do to manage this change in the width of the foot that usually causes the issue. You mentioned about corns, you mentioned about hard skin, how to deal with those. Now, obviously, it depends on where they are. And now this is where we are hoping that this platform eventually will assist us in helping even further, because I don't know what podiatrist situation is over there. So obviously, if people have a corn, what we generally advise is to gently use a file on it. That's like the first thing to do. But corns are in different places, present in different ways. When you have a corn on your heel, usually those are hard, very tough, hard wearing. If you have a corn in between your toes, usually those are very soft and very sensitive and very painful. So you can't treat a corn on your heel the same way you treat a corn in between your toes. If you have a corn on the top of your toes, those are even easier to treat because those are 99% caused by pressure. So if you have a corn on your toes, it's usually because there's pressure on it. If you have a corn underneath the foot, now that's a different story. That's pressure coming from the way you walk. So you can change your shoes. It just means there's something going on. Maybe the way the person's foot is aligned. Now, in that kind of case, usually what we say is use a file gently. But you see, this advice I'm giving you is based on principle, because I have seen people where the corn can be 1 centimeter deep and we have to debride it with a scalpel, under clinical conditions. We see some people that have very little hard skin where they can just use a file gently on it, There are some companies where they sell corn removers made with chemicals. Usually the active ingredient is salicylic acid. Now, we never advise diabetics to use that because, believe me, most times, we're trying to fix the problem that the hole has caused, the acid reaction has caused. So diabetics have to avoid using those caustic treatments, and they probably need to find out locally what is available. Maybe they might have to go online. It might mean they have to travel a bit further out to get someone to treat that problem, because a lot of people we see with corns, sometimes they need their treatment maybe once a year, twice a year, 3 times a year. Sometimes it could be a bit more depending on what their particular situation is. So I will say if they could, go and get treatment with a professional that is qualified to deal with the corn, because that way they will have it dealt with properly. You mentioned about drying in between the toes. That's very important, as you said. Sorry, can you remind me, did you say you're a nurse?
I'm a nurse, yes.
Yes, exactly. So you are aware as a professional. We always give that basic advice: dry in between your toes and cream underneath your feet. So even when they have corns, if they apply cream, for example, whatever is available locally, but I know shea butter is excellent, and I believe shea butter is locally available. That can do wonders. Even if a person has a corn and they use the shea butter and it softens it, a corn that is hard like stone is more painful than a corn that is nice and soft. So some people, even if the corn is there and is soft, they can manage their lives and it's easier than if they don't cream it, or do anything. So the general thing is advise them to moisturize, gently file, and then seek professional help if debridement is necessary.
Thank you.
You're welcome.
Thank you. We have another question from Azari. He or she says, I'm not very clear on the capillary refill time. Can you go through that demo or explanation again, please?
Capillary refill time generally is the time it takes for the areas to fill when you blanch the skin. So generally speaking, it's about 2 seconds. So normally when you do this to someone and you take your finger away, 2 to 3 seconds, the color should come back again. Now, there are some times where people have arterial problems, and obviously arterial problems is to do with the blood coming back to oxygen, like to provide oxygen to the tissue. So once you do that, there are some people it could take 8 seconds. Some people you do that and your fingerprint is still there, maybe 10 seconds later. So obviously it's showing that there's a poor capillary refill time, which could be an indication of circulatory problems. So we don't just take capillary refill on its own. We look at the big picture. We look at the pulses, we look at the temperature, we look at the color. We ask them a few questions, like I think Yemisi mentioned earlier, if some people are complaining that they have maybe pain when they're walking, it could be an indication of some sort of blockage. So capillary refill time is one of the tools that we use when we're assessing circulation. I hope that helps.
Thank you. Okay, we have some more questions. Are we allowed to use callus removers or files?
Again, excuse me, like I mentioned, unless I see the area the person is using it for, generally speaking, I always say filing is better. But then again, like I said, if you're filing the skin in between your toes that is very sensitive, that could end up causing it to break. But generally speaking, if you're filing the skin underneath the heels, anywhere where it's tough, where you have hard skin, filing is good. Now, when you say callus remover, I don't know what you mean. Callus remover could mean different things. Do you mean an acid? Do you mean a plaster? Do you mean a knife? Do you mean I don't know what you mean by that. So you have to be clear about, callus remover.
Okay, I'll just unmute the person asking the question, Donald, and you can ask your second question, Donald, and so you can clarify what you mean. So please unmute yourself. There you go.
Okay. Okay.
Yeah, we
Hello.
can hear you. We can hear you.
Yes. By callus remover, I mean there are those that look like files, which you keep using over the callus gradual over time, not the chemical removers, not chemical removers. I mean metallic, just like files.
Physical
Continuous use continuous use over the callus will reduce their size and all of that. Can we use that? Are we allowed to use it without a podiatrist supervision?
Are you a nurse? Do you mind if I ask?
Sorry, ma'am?
Are you a health professional?
Yes, I am.
Oh, excellent. Okay, and have you been trained as to, you are familiar with the anatomy of the foot and the issue with neuropathy and things like that, yeah?
That's correct, ma'am.
Excellent. Well, I mean, as a nurse, I cannot instruct you and tell you whether you can or you cannot. You have to use your clinical judgment because, you will know what to do in terms of, is a foot a viable and a healthy foot to use something like that on? Because obviously what we do, I mean, as a podiatrist, what I tend to do is I judge the quality of the person's circulation. For example, we might, if I hem them, some people we hem them when we are treating them, are they an anticoagulant? There's a bigger thing. What's the quality of their skin like? So obviously, if you make a clinical judgment that it's fine to use a callus remover that's like a file, that wouldn't cause maybe damage, because you have to obviously know what you're doing, which I know you do, but you have to know how much skin you're taking off. You know what I mean? So it's not right for me to say, yes, you should do it. I don't know what your clinical, So obviously, in principle, it is a good idea, but obviously it depends on what part of the foot, how much callus it is, how confident you are, what exactly is it? Is it sterile? Is it not sterile? So there's just a few other things, to consider. But in principle, it's a good idea. Yeah.
Thank you so much, ma'am.
You had a second question? You had a second question about the use of Vaseline?
Yes. I did ask whether Vaseline could be used to lubricate the interdigital clefts.
Now, you see, that is not something we advise. We don't.
Can we use Vaseline to do that?
No, because interdigitally it should be dry. So what we try and encourage is dryness. What we tend to suggest is Vaseline is good for underneath, yeah, as long as there are no breaks in the skin, underneath, on the top, dorsum plantar. But interdigitally, you want to keep it dry because of the tendency for when you have the toes are usually close together, number one. Then number two, they're inside maybe socks. Then number three, they're inside shoes. Then number four, they're in the climate where there's humidity. If we put Vaseline in there, that may encourage maceration, which we don't really want. So keeping the feet in between dry is usually the best thing to do. So advise your clients, dry in between your toes. That's all they need to do. No Vaseline in between, but they can put it underneath and on top.
Okay. We have a comment from Richard. Excellent presentation. Which professional would you refer the shackle foot to if you don't have an MDT team immediately available, being an emergency?
Now, you see, once again, Professor might want to add to this, but I will give you my perspective, and my colleagues as well may want to add to this. A shackle foot doesn't happen overnight. It's something that develops, and usually over here, when we see them, especially when we do the temperature change and the temperature, we measure the temperature, you can tell there's something going on within those joints, that they're breaking down, and there's something going on there. So usually what we tend to do is we try to catch it before we get an ulcer. That's the plan. If you don't, and then when the foot, basically what happens with the shackle foot is, I wish I could share my screen, and I'm going to try and do that because I know I have it on here somewhere. What happens obviously is the foot collapses, basically. You don't have an arch, everything collapses, and it's weight bearing in the wrong places. Then you get the ulcers. So what happens, what we tend to do here is people get referred to orthopedics. and they get special shoes made with points to take out pressure that could cause, breakdown. So if you have a shackle foot that also has an ulcer, then obviously that definitely needs to have some form of clinical intervention. So I can see you saying if you don't have multidisciplinary team immediately available, being an emergency, then you have to treat the ulcer. So obviously it's an open wound. You have an open wound, you have to treat the open wound, and then you have to have a plan. So obviously someone walks in with a developed shackle, there's an open wound, you treat the wound, you have to have a plan, and it will probably require, depending on how bad it is, some sort of joint clinical plan. Because with shackle foot, you have to look at the long term. You can't just keep treating one wound, it heals, then you wait for the next wound to come. You have to have a plan, a long-term plan of footwear is usually what is required. Because once you heal the first ulcer, you know you have a shackle wound, then you have to plan with the hope of preventing this happening again. Because the emphasis we always have, which has been instilled in me since I started doing diabetic footwork, is prevention is always the best thing.
Thank you. Professor Fasamade, do you want to?
Yes. So when we are talking about charcoal foot, just as Fumi has beautifully explained, we are talking about a foot that the nerve supply has been damaged. And usually such a foot is insensate, meaning it has no feeling and it is totally disorganized. So if you see a patient with charcoal foot, even from far, most professionals will know what it looks like. The leg is totally disorganized. It looks like just a bag of tissue. The toes are pointing in different directions, some under, some on top of each other. The normal, beautiful arch of the foot is gone. So that type of foot, the patient is likely to be wobbling. He won't be able to walk on it. It will be very, very unstable. Usually patients that come in at that stage is like the end of the road for the foot if care is not taken. And the people that manage the shackle foot include about 3 or 4 groups. We have the orthopedic surgeons, we have the podiatrists, we have the orthotists, that's those who are in charge of preparing special treatment shoes. We also have physiotherapists and to some extent also the neurologists. So very good. That is a typical picture of a charcoal foot, which I think Fumi has put up. So you can see how it looks like. The arch of the foot is gone and the foot is not looking like the normal foot should look like. So this is what a charcoal foot is like. So it's a multidisciplinary team that manages it. Otherwise, this type of foot will lead to an amputation within no time. So you can even see the picture. You can see sores. You can see a hammer toe. You can see rocker bottom foot. You can see collapse of the mid portion of the foot. You can see so many changes. You can even see the skin is dry, is cracked. So this is what a typical charcoal foot looks like. So it is a multidisciplinary team and usually might involve treatment shoes or total immobilization of the patient on admission to save the foot.
Thank you. Fumi, did you want to say something? Just unmute. You need to unmute. You need to unmute.
Fumi is muted.
I asked her to unmute. There you go. Oh, she's on mute. You're still on mute, Fumi.
Okay, hold on a second.
Yeah, we can hear you now.
Is that better?
Yes, we can hear you now.
Excellent. I said thank you so much, Professor, for explaining that. You did it much quicker than I probably would have done it. So it's a good job you did that. Yeah, so that is really what it is, because we try to avoid getting to this stage, as you mentioned. We don't want to get here, so I think enough has been said about that already. I hope that assists. Thank you very much.
Yes, thank you.
How do I stop the share?
Chigini is saying that yes, it is also advisable to avoid weight bearing to prevent more damage. That's just a comment. Another question: if the charcoal is active, the patient needs to offload for at least 8 weeks, depending on the damage happening at the time. This is from Chris. If the charcoal is inactive, then you can look into bespoke orthotics and bespoke footwear to accommodate the charcoal foot. That's for Prof and Fumi. Any comment on that? On that comment?
Well, the comment is very, very correct, and I'm sure the person is probably a podiatrist. Offloading means that the simplest way to offload the foot is the person goes for admission, bed rest, at home or in hospital. That is the simplest offloading method. Other methods of offloading include using crutches, using wheelchairs, or using total contact casts. So these are different ways to make sure that that leg is not bearing weight. So for most patients, even those that just have a sore, staying in bed for some days or weeks goes a long way to help the healing of that foot. So that's a typical picture that was shown. That person has no business walking around or coming to hospital as outpatient. He should either be on admission or he should be at home and then receiving home care to make sure that something more sinister doesn't affect the foot.
Thank you. Okay, Fumi, any last comments?
No, thank you. Just to say, I mean, I believe, the panel has assisted with the explanations, and, with the hope of this, what we're doing today, we're hoping to avoid, such getting to the stage of shackle foot joints. Yeah.
Okay, you mentioned at the beginning about, I think some people missed that because I had a question about gloves.
Yes. I simply said, we put gloves on. Obviously, I'm not using gloves because the shoes I'm expecting are mine. So what I said is, obviously, when you're doing anything like this, you have to put your gloves on, obviously, because you don't know what is in there. There could be a bit of blood, other things. So yeah.
Okay, but what when you're doing the foot examination as well?
Oh yes, when I do the foot examination, I always wear gloves. It's just second nature. The minute I see a patient, they come in the door, I wear gloves. That's the way I work. Everyone works differently, but that's the way I've always worked. Yeah.
Thank you very much.
Thank you so much.
All right, let me just see if there's any more questions. No. Okay, so we will go to our third speaker for today. Her name is Kemi Ojo. She's a podiatrist as well, and she specializes in general podiatry care, diabetic foot, and she mentors students as well. That's good. So Kemi, over to you.
Yeah, thank you, Flora, for the introduction. I'm aware today we have clinicians and we have the members of the public. So I'm just going to keep this very simple so everybody can easily understand. Okay, so the main objective of this presentation is to give you a simple, concise information of how peripheral arterial disease presents in a diabetic foot. So I'm going to be focusing on the symptoms, how you can assess, and the treatment for the peripheral arterial disease. So let's get started. I'm going to share my screen now, just share my PowerPoint. Okay. So first and foremost, what is a peripheral arterial disease? It's also known as PAD, that's the abbreviation for it. So peripheral arterial disease is the narrowing or blockage of the blood vessel called artery, and it's mostly caused by atherosclerosis. So atherosclerosis is the buildup of fatty plaque or cholesterol deposit in the walls of the artery, and that limits the flow of blood to your tissues and organs. If I can direct your attention to the picture on the right, you see what a normal artery looks like. So the inside is free, there's not any deposit, no cholesterol accumulating inside the wall of the artery. So that allows for the free flow of blood to the tissues and organs. The next picture here shows you what an unhealthy artery looks like. So you can see all this yellowy, fatty plaque and cholesterol that's accumulated, over the years in the artery. So with this, the blood will not be able to flow, through to your tissues and organ. Okay, so as a result of a reduction in blood flow, it leads to gangrene, it leads to ulceration, and ultimately amputation, like the previous speakers have mentioned. So peripheral arterial disease usually presents in the lower extremities, so in the leg and mostly the feet. And it has been reported that 1 in 3 people with diabetes, especially diabetic people that have uncontrolled blood sugar, go on to develop peripheral arterial disease. And when you have peripheral arterial disease, it's a general marker that you can develop heart attack and stroke. Okay. It has also been reported that peripheral arterial disease is the single most likely cause of lower limb amputation in people with diabetes. Like I mentioned, if your diabetes is not well controlled, you might end up with amputation if you have a peripheral arterial disease. And most time when your patient presents to you with peripheral arterial disease, reaches its advanced stage. So this is why it's important when they come to your clinic, for routine treatment. You have to carry out vascular assessment regularly, take comprehensive patient history, and you have to educate them on the risk factors. I'm going to be talking about risk factors in the oncoming slides. So you have to educate them on it. And if you notice any problem, please refer on to other medical specialists to prevent adverse complications. Right, so the slide here shows you the anatomy of the arteries in the lower leg and feet. So I won't dwell into much into this. So if you're interested, you can always go back to this to learn more about the arteries in the leg and in the feet as well. Okay. So who is at risk of developing peripheral arterial disease? As I've mentioned earlier, and as the previous speakers have mentioned, if you have diabetes, you're at high risk of developing this. And if you're a smoker, smoking on its own puts you at a very high risk of developing peripheral arterial disease and also cardiovascular conditions such as heart attack, stroke, amputation. However, if you're diabetic and you smoke at the same time, your risk of developing this triples. So you're at a very high risk of developing this condition. Other risk factors include if you're overweight, if you have high cholesterol, so if your lipids are very high, and if you have a sedentary lifestyle, if you don't do exercise, if you don't move your body, if you don't walk around, if you have any family history of peripheral arterial disease or cardiovascular disease like high blood pressure, if anybody in your family has already suffered from stroke, you might want to take that into consideration. And aging, as we age, the body is not what it's usually like. Things don't work as it should do. And if the patient itself already has a heart problem, if they already have high blood pressure, if they suffer from heart attack or stroke, so there might, their risk of getting peripheral arterial disease, increases. So we're moving on to the symptoms of peripheral arterial disease now. So how would this present in your patient? Okay. So the number one symptoms, which is mostly common, is leg cramp, or what we refer to as intermittent claudication. So this is the most common symptoms of arterial deficiency in the lower limb, in your legs and feet. Okay, so the muscle cramps can occur when you in the hips or thighs or in the calf muscles of the leg, either when you're walking, when you're climbing stairs, when you're exercising. And the pain or the cramp tends to go away when you stop the activity. So if you stop walking, then the pain disappears. So sometimes you might just have walked for like 50 yards or 45 meters, and you can see yourself grabbing the back of your leg due to cramp. So the reason why you're getting this cramp is because the muscle of your leg is not getting enough blood supply due to occlusion. There's a blockage in the artery. So the muscle is not able to work as it should. It's not getting oxygen. It's not getting nutrients. So that's why you get this buildup of lactic acid and waste product that the blood can't clear off. And this leads to the pain you're getting. And if you can look at the picture on the right-hand side here, so This diagram shows you the location of where the artery or the blood vessel is blocked. And on the other side, it shows you where you might likely get the cramp or pain in your in your leg. Okay, so if it's the femoral artery, which is just, next to your groin here, you might get, the cramps and pain in the calf muscle or in the thighs. So yeah, you can just look more into details, if you want to learn more about this. Another symptoms that the diabetic foot does present with is acute limb ischemia, ALI. So this is a sudden drop in blood perfusion or lack of blood flow to your leg or feet or foot. And this put the limb at risk of necrosis, which is gangrene or tissue death or even amputation. Okay, and this is usually caused by thrombosis, which breaks off from the atherosclerotic plaque, from the accumulation of those fatty and cholesterol, deposit in your artery. So that can break up and just occlude or, cause blockage in your artery. Or sometimes it could be an embolus, like a blood clot, that comes from the heart, and that travels down, into the leg and just, cuts off the blood supply. Okay, so in order for you to be able to recognize the acute limb ischemia in your patient, or if you're a patient yourself, the things you should look out for is we use the 6 P's. It's easier to remember that way. So if you're getting pain, like I've mentioned, if you're getting leg cramp, you're getting pain in the back of your legs or in your thighs, so you might want to, consider that. If your legs look pale, so which is pallor, so anytime you check your legs and feet and they appear pale, or you just slightly elevate your feet and they go pale, so that might signify there's a bit of issue with your circulation. Pulselessness. So if your clinician check your pulse, as Fumi has demonstrated on how to check pulses on your patients, if you check their pulses and it's absent or it's diminished, so that indicates there's a problem with the blood flow. Paresthesia, so if you're getting pins and needles, burning sensation, so it might mean your tissues are starving of oxygenated blood. So the nerves also get affected because the nerves also needs blood to function. If your feet is very cold, so that might indicate there's a problem. I think the previous speaker already mentioned about checking for temperature gradients in the legs and feet. Paralysis, if you're unable to walk due to the pain. Okay, so if you notice any of these signs or the symptoms, please go and speak to your doctor or a health professional, or the appropriate health professional, so that they can put the appropriate management in place, in order to prevent you getting gangrene or ulcers or even amputation. So the next one here is critical limb ischemia, CLI. If you come across this is a foot emergency, and you have to refer, immediately to the vascular specialist in your area. So it's an advanced stage of a peripheral arterial disease. So the blockage has reached an advanced stage. And the way you're going to notice this is if the patient presents with rest pain, okay? And if they have ulcers that's not healing, and if there's gangrene, the tissue is, they're dying off. So the rest pain, your patient might tell you they have a continuous burning pain in their legs and feet. And usually it gets aggravated if they're in a reclining position or if they elevate their leg, okay? And it's relieved by sitting down or standing. Most patients with critical limb ischemia, they often have to hang their feet and leg over the bed when they're sleeping, or they can't even lie down, flat on the bed. So they have to sleep in a chair. And they have to do this because they need the gravity to just help with the blood flow. So if they report this to you, you have to take the necessary action. And the non-healing wounds and gangrene, they usually present further away from the leg. So that's going to include your toes. As you can see the pictures here, you can see the gangrene, the ulcers in between the toe. Basically, you know, this feet, you know, they might not be able to, you know, come back to normal. So yeah, if you notice this, you know, you have to please get the professionals involved immediately. Otherwise, they might have to just amputate the legs. So what are other symptoms for peripheral arterial disease? So like I said, if you've had a wound for a long time and it's not healing, if your legs appear pale or they have this bluish coloration to it, if you look at the nails and the hair on the skin or on the legs and toes, if there's poor growth of them, then that might signify they have issues with their blood flow. And also the previous speaker for me also mentioned the temperature gradient. Normally, if you use the back of your palm to run from the leg to the feet, it should be warm to cool. But if you're getting, you know, warm to perishing cold, you know there's a problem going on. Okay. So how do we assess a limb for peripheral arterial disease? First and foremost, before you get any diagnostic tool out, you have to get a patient medical history. So you have to get a thorough patient history. You have to know the medication they're taking, if they have any family history of cardiovascular or peripheral disease. And then you can get their history of pain. When are they getting the pain? What are they doing when the pain comes on? Whereabouts in the leg or feet is the pain presenting? Okay, so after this, then you can go on to, you know, examining their feet and legs. So as Fumi mentioned earlier, you want to take, like I said as well, you have to check for the temperature gradient, the capillary refill as well. You have to check the hair growth. You have to check the status of the skin. Is it pale? Is it cold? Is it smooth? Is it shiny? Is it dry? Is it very thin? And also, is there any presence of ulcer? So the next, the other assessment that you can do includes palpation of pedal pulses, Burgess test, Doppler ultrasound, ABPI, toe pressures, Doppler scan, MRA, CTA, peripheral angiogram. The ones I've highlighted in bold, those are the ones I'm going to be discussing further. And typically, these are the ones that are available to us in the clinic. The ones below it, you might need to refer to vascular specialists for them to carry out this test, okay? So the next one here is a palpation of pedal pulses. Fumi has already demonstrated to us how to do this on a patient. So the pulse from the foot is located on top, which is the dorsalis pedis, and the inside of the ankle is your tibia, posterior tibia artery. And the most important thing when you're palpating for pulses is to check it bilaterally for comparison. So if you're a patient, if you go see your clinicians, make sure you know they check both pulses on both feet. Okay. It is also important to note the pulse rate and rhythm of the pulses. Okay. So in my practice, I've managed to refer patients onto other specialists, for example, the doctor, because sometimes when you're palpating the pulses, you might find that some of them are irregular. And irregularity of pulses might indicate they have atrial fibrillation. So that's when the electrical, you know, nodes in your heart are not working properly. So they're not making the heart to pump, you know, blood efficiently. And that might give rise to having clots, which can later on, you know, lead to stroke. So your patient might come to your clinic just to have their feet checked. And if you find this, you might be saving them from having stroke. Okay, and if there's also increase in pulse rate, it might suggest hyperthyroidism if that is not already mentioned in their medical history. Decrease in pulse rate might, you know, show that they have heart blockage. And if you can't find their pulses at all, you can't palpate them, it signifies, you know, there's impaired blood flow present in their feet. So another hands-on test that you can do is called the Borges test. Clinicians can do this, and you as a patient, you can do this. You can get one of your neighbors or one of the family members to help you with this. So with Borges test, this test is used to check the adequacy of blood flow to the legs and feet, okay? So in a normal leg with normal circulation, when you elevate your leg even at 90 degrees, the color should still remain in normal. It should still remain pink. And when you drop down the foot, the color should return to normal. However, if you have impaired circulation or in an ischemic foot, if you raise the leg up, you will see the legs go pale. Okay, and when you drop down the leg again, you see the color comes back from pink and it goes to bright red. So that shows you, the circulation in that leg has been compromised, okay? And the diagram here on the right shows you how to carry out a Borges test, which is very useful for clinicians and patients to do. So the Doppler ultrasound assessment. So Dopplers, they're a valuable tool that we use in the clinic. So if you can't palpate the pulses, if you're finding it, if you can't find them, you can use the Doppler, okay? So Doppler, they're valuable tools to use to assess the arterial flow of blood to the legs and feet. So the Doppler produces a sound which comes from the tissue, and from the sound reflects back from the blood moving in the artery. So the Doppler sound, you could get triphasic sound, which is normal and healthy. The biphasic sound is also normal, whereas if you're getting monophasic sound, that means the artery is not healthy at all. I've provided a link down below here. It's very, useful. I would encourage people to go, to go watch this video, because it shows you how to use a Doppler properly, how to angle it, and it also demonstrates the waveforms. So if you're not sure about the sound you're getting, you can, look at the waveforms as well, to help you determine, it helps you determine, what you're listening to, okay? So another test you can do is called ankle brachial pressure. So the ankle brachial pressure is a non-invasive method of assessing the flow of blood to the legs and feet. So this is the ratio of blood pressure in your upper arm compared to the blood pressure in your lower arm, okay? So this is carried out by the clinicians using Doppler with the coupling gel, and they can use the blood pressure cuff as well. I've provided a link down below here as well for you to watch on how to carry this test out. So once you've calculated your ankle brachial pressure index, you can use this chart to classify your patients on the risk, on how diseased their vessel is. So the normal ABP height should be between 1.0 to 1.4, okay? And the list goes on. So be very careful, especially in diabetic patients. They tend to get a high reading or a normal reading. And this is because the artery has become hardened, so it's become stiff. So when you put the blood pressure cuff on it, it's incompressible. So that might give you a normal reading, but it's a false reading. So don't just use ABP high to diagnose someone of peripheral arterial disease. You have to do other tests as well, okay? So how is peripheral arterial disease treated? So it's a combination therapy. So we have lifestyle changes, medication, surgical interventions, and you have to always educate your patients, okay? So the lifestyle changes include smoking cessation. So if you're a smoker, please, you have to stop smoking. There's no using e-cigarette, or I'm gonna have two, 3 cigarettes today, won't do it for 3. You have to just cut it off completely if you're interested in keeping your leg. Control of blood sugar. You have to control your diabetes, very important. And you have to control your blood pressure as well. Eat a very healthy diet. okay? And you have to move your body. Exercise is good for everybody. It's good for cardiovascular health, even if you don't have diabetes. So make sure you get physically active. And also people who get leg cramps, like I've mentioned earlier, the intermittent claudication, walking is really good because it helps you build collateral circulation around the blocked artery. So when you're walking and you're walking through the cramp, your body will, start developing other artery, just to help, take the blood down to your tissues. And the surgical intervention, one of them is angioplasty. So angioplasty is a minimal invasive procedure done by the vascular surgeon. So what they tend to do is they clear off the fatty plaque and the cholesterol deposit in your in the artery. So they strip that off, and then they put a stent into the artery to keep it open so that the blood can flow freely. Another one they could do is bypass surgery. And this may be needed if the artery or the blood vessel is very narrowed. So if they can't perform an angioplasty, this might be the next stage. So typically they take a vein from another part of your body. Typically they use the one in the leg, and or they might use a synthetic blood vessel. And what they tend to do is they attach this the vein to the blocked artery, so they attach it above and below, so they can redivert, the blood flow to the legs and feet. So medication treatment, you have to liaise with your doctor, so they have to control your blood pressure. So you might be taking, blood pressure tablets, statins to lower your cholesterol, and you may want to discuss about having antiplatelets as well to prevent blood clots, because blood clots also can, occlude your artery or block your artery and prevent the blood from flowing down to your leg. So in summary, diagnosis of a peripheral arterial disease should not be based upon the findings of one clinical test alone. It is important to check other risk factors such as hypertension. You want to check the hyperlipidemia, the high cholesterol. You want to deal with smoking, diabetes, obesity. So all these things must be dealt with. And poor arterial supply reduces healing of wounds. It increases your infection rate and can lead to the amputation of your leg. And regular assessment, patient education are very vital to prevent limb loss, and it saves lives. Thank you. So that's the end. So if you have any questions, please feel free to send them through.
Thank you very much, Kemi. Please stop sharing the screen, and then let me just have a look and see if we have any questions. So we have a question here from Donald. At what age should you not take aspirin or clopidogrel? Wow. Okay, that might be for Professor Fasamade and Dr. Agum.
Yeah.
Dr. Agum, you can start while I look for Professor Fasamade to unmute him.
Okay, that is not related to age, whether you take, when you can take aspirin or clopidogrel. Basically, is based on your risk. And when they are putting you on aspirin or clopidogrel, there are other things you need to consider. In the UK, we use what you call some risk tools. And basically, these are tools that you use to calculate the risk against benefit. So for you to put somebody on aspirin or clopidogrel, you need to be sure that the aspirin that you're putting them doesn't kill them instead of the condition that you are treating. So we have 80-year-olds and all that are on aspirin. A lot of it depends on their risk. That means the risk of the condition killing them or the risk of the aspirin. So it's not related to age. If you're talking of younger people, Then things like aspirin you need to avoid in children and all that. But anybody above teenage years that has anything can, once you calculate their risk against benefit, you can start them on it. I wonder if anybody else has anything to contribute.
If you'd like to make any additional comment, please just let me know. Professor Fasama, did you want to make any comment or?
Well, I quite agree with Andrew that when you are giving a person aspirin, you have to consider the risk because the only thing probably the person who is asking the question is asking because many of the risk factors get worse as you get older. For instance, people might have bleeding tendencies, they may have ulcers when they're in the elderly group, they may be on many medications. Some people are already on aspirin and then you now go and put them on clopidogrel and they probably won't tell you. Or some people might be on corticosteroids because of arthritis and you may not remember to tell you, go and add aspirin and then they now die from bleeding. So what I just do in my practice when I'm not too sure of the person's history, if I see they are very, very old, maybe the person is already 80 years old, I will be very, very cautious to prescribe aspirin in somebody 80 and above. But otherwise, anybody can be on aspirin once you have excluded peptic ulcer or reflux or other drugs that aspirin may work together with.
Okay, thank you. We have a comment regarding claudication. It might be necessary to determine the claudication distance, which can be a pointer to the progression of the disease. Kemi?
Yeah, that's important. So like I mentioned, normally if the way we classify patients, that we classify their degree of arterial disease, if they can't walk 50 yards, then that's how you know the disease has progressed to an advanced stage. Yeah, so claudication distance is really important and it's a measuring tool as well. Once they've gone for the supervised program, so they should be able to walk further. So if they can't do 50 yards, now they can walk on 100 meters or they can do further exercises. So that shows, their blood supply is improving. So yeah, that's true.
Okay. Any other questions or comments, please? For our last speaker? Before we go into just any general questions for all the panel. Okay, we have a comment from Lawal. From my experience, many people take aspirin without consulting their healthcare professional. They take as advised by friends. Okay. Yes, Professor Fasamande is agreeing there. Yes. Aspirin should only be taken on direction of your healthcare professional, your doctor or your pharmacist. Okay.
That's why our pharmacists too are also custodian too, because sometimes they bypass all the healthcare professionals and they all go straight to the pharmacy to buy the drug. But a very professional pharmacist like pharmacist Lawal, I'm sure she will ask who prescribed it or what do you want to use it for? Are you sure you have side effect or adverse reaction to similar substances in the past?
Thank you. We have a question from Sister Jai. Please unmute yourself. What? Okay, there we go.
Yeah. I have arthritis and my right knee, it's already bent somehow and it causes some friction if I have to walk long distances. How can I do my exercise without causing more harm to my already bad leg?
Okay.
What's going on?
So, Mrs. Person who just finished speaking, if you are having pain in any joints, maybe you have severe arthritis either in the ankle or in the knee, it does not preclude you from exercise. There is an exercise for every kind of person. It just might be you need to consult with a physiotherapist. But we do know that for people who have arthritis in the knees, exercise like swimming is quite good. You could swim. For a person who has lost a leg, you can have other aerobics using your arms. For people who cannot see, you don't expect the person who is blind to jog. So there is an exercise for every particular type of person. Some of them may just be using dumbbells, carrying weights up and down. Some of them can include dancing. Some of them can include swimming. You look for the one that suits you. So every health professional should look at the person in front of him before advising on you go and jog or you go and walk, or you check, and if the person has diabetes and has charcoal foot or has had a previous operation on the foot, there is a type of exercise that he or she can do. But again, in this case, it is a multidisciplinary prescription. For a person who has had surgery on the foot, or a person who has had fractures, or a person who has arthritis, you need the input of the podiatrists, the orthotists, the physiotherapists, the surgeon, the physician, and the nurse. So everybody is involved.
Thank you very much, Professor Fasamadi, for that. Okay, so we will now open the floor for questions. If there were questions you wanted to ask earlier on, but you were not able to ask, just raise your hand or put it in the chat box, and all the panel are ready to take your questions. So it can be from any of the speakers from today. You can go ahead and ask. Or if you have any comment you want to make, just raise your hand or type it in the chat box, and then we can take that. Okay, we have a question from Daily. How can we sensitize or improve the awareness of diabetic foot care in Nigeria? This is part of what we're doing, but anyone else can take that. Dr. Agun, do you want to start?
Yes, I can talk. Part of what we're doing now is part of increasing the awareness of the lack of foot care, and also empowering more people to be able to give foot care. But I think the main thing, especially during our program that we discovered, was the lack of information. I think the key to management of diabetes as a whole is information and education. The first thing is to avoid being diabetic. And then when you become diabetic, you need to know that it's most likely a lifelong disease, especially type 2 diabetes. Type 1, definitely. And if it's going to be a lifelong disease, then you need to inform yourself on how to manage it. Because if you manage your diabetes properly, it can actually go into remission. And when we start talking of foot care, managing your feet is preempting it so that you don't develop ulcers and infection or end up with amputation. And all of that are preventive stuff. So I think it is important, the more people that educate themselves on foot care, would then make the service available to the millions that need it. I mean, basically, there are very few people that offer foot care, but I think the key, if we then get to a situation where some universities start to train podiatrists in Nigeria, it will very quickly spread, and hopefully that will improve it. I don't know if other people have anything to add.
Okay, I think Dr. Bafemi has something to add. I'll just ask him to unmute.
I just wanted to add the question we're talking with one of the presenter was talking about Charcot's foot, and to me, is a medical foot emergency. One of the things, if anyone has that kind of a problem, there's the air cast walker, which will be very supportive because that will actually take the pressure off the foot and reduce the risk of the fracture, because the fracture with Charcot's foot is has a poor prognosis. So if that is possible for that person to get the air cast walker, that will really help more or less until the person can see a professional. But also someone did mention something about bed rest. To me, bed rest I mean, unless you cannot get air food worker or something like that will help take pressure off the food, bed rest is bad news, because then that just takes that person off being able to be active, and that comes with its own problems of possible DVT and with all its ramifications. That's just my comment. Thank you.
Thank you. Okay. Professor Fasamande, any comments about improving food care in Nigeria for diabetics?
Yes, I think what we are doing here today is part of it. It's like a drop in an ocean, but we also know that many drops make the great oceans. And we are hoping that what we are doing here will inspire others, other NGOs, other patient support groups to do similar things. And as Andrew mentioned, it's unfortunate that up till now we don't have schools that are training podiatrists. Nigeria doesn't have, in the employ of any of the government centers, qualified food specialists, podiatrists, chiropodists, and other support staff in the management of food. So we are hoping that people will take the message to others so that we can have, even if it is a diploma program or a degree program, so that we can train specialists in this very, very much needed field. And or if you can't train them, we attract those who are outside the country to come back and set up shop or set up training centers. A few of my colleagues have tried to do that, but an endocrinologist or a diabetologist is not a podiatrist. We are just trying to fill in the gap because we don't have any locally. So we are hoping that with time, people will see the need to have this field well developed in the country.
Thank you. Anyone have any comment about improving services for food care in diabetics in Nigeria? Anyone else? Okay, there's a question for you, Kemi, regarding looking at pallor in someone who's dark skinned. How do you know the difference? And then you mentioned about the Burgess test, where the skin will go different colors. How does it work for dark skin?
Well, for dark skin, I mean, you have to know what your normal color is. So when you elevate your leg, you can see the color just starting to diminish. It's going to, I mean, if you're light skin, this is easily seen, but dark skin, that might be a bit tricky. But that's why I say you don't have to rely on this single test alone. Okay. There are other tests that you can do as well. So you can check the nail bed, and you can see, the nail bed, the color might just go from the pinkish color, and it can just go into a pale color. So that's one way of doing it.
Okay.
And for the Burgess test, that just measures the adequacy of blood flow in your artery. So in a normal patient or in a normal person without any peripheral arterial disease, if you raise your leg up, for 30 to 60 seconds, the color should still, remain normal. Okay, and when you drop it down, the color returns back to normal. But if you have ischemia or your blood flow is not good, even just elevating the leg like 20 degrees, the color just diminishes. It just goes pale. Okay, so that shows you, the flow of the blood is not adequate, to your limb. Okay.
Thank you very much. Okay. Any more questions or comments?
Laura, can I add to that?
Yes, go ahead.
You can tell when a black person is pale.
Okay.
The skin actually looks pale. You can tell the difference, as Kemi said. You actually can see the blood actually blanch of it, and though the skin will still be black, you will know that this skin looks pale. Yeah. No, it almost looks grayish in some ways. Yes, you can tell. Yeah, you can tell.
Okay, thank you. We have a comment regarding increasing, food care access in Nigeria. From Marcia Edwards Collins, as Dr. Agun has stated, general food health advice will inform the population to aid prevention for all. and reducing risks. Also, increasing careers information on the variety of healthcare professions available might also help. Yes, I don't think even when I was in school I ever heard that one could become a podiatrist. Never. It was not one of the professions that was mentioned. So yes, I guess with what we're doing, awareness is also part of the solution. Okay, do we have any more questions or comments? Oh, okay, we have. Go ahead, Sister Jai.
I may be using the word we instead of I. To thank the House, all of us, for bringing up this topic at this time. And I offer myself, if I can crave to be part of the team that could help others. Maybe some that are not aware of this topic who may need the help such as this, or the fact that I have a case to be addressed, which I'll be contacting you later on, I could be a kind of reference point to others who may need similar assistance. So I am offering myself to support the House in whatever way. I'm not a professional, but since I am a patient, I am a professional in some respects. That is, I can speak of myself as having gone through certain ordeal and having got some help along the line and having been able to cope with the situation. Thank you.
Okay, thank you for that comment. Thank you very much. Okay. I believe we do not have any more. I believe we don't have any more questions at the moment. So I will hand over to John. He's going to say a few words of thanks and will give us some more information as well. John?
Good evening, everyone. I hope you can hear me.
Yes, we can.
Let me start with sharing my screen because I have, hang on. Trying to share my screen, so.
Technology.
Oh, okay. So, good evening, everyone. My name is John Akere Sangmedo, and I'm the project manager for Gentavines Health Foundation. And today, thank God for the program, we're able to get about above 60 people, onto this program. And there are lots of things. It was very rich and very informative. And we have to end now or close the program. So there are a couple of things that we have to talk about very quickly so that all that we've done here and all of that has meaning, and we can carry the difference that we're making now forward. Okay, so the first thing we have to talk about actually is sponsorship. As Dr. Andrew mentioned earlier on and all of that, we're a non-profit, an NGO and all that relies solely on donations from well-meaning individuals and organizations. Okay, so really, all the money that we get, any money that we have, it comes from donations from people like all of us that are here on this platform here, and corporate organizations. So we're trying to encourage us all to either donate what we have if we can, or at least look into our network of people that we know, our network of connections and all of that, and see if we can have people that will be willing and able to help the cause. Because as you can see, this was a very rich and informative program that all of us would have benefited from, all of us that have attended, from healthcare professionals to us laymen and all that, to to diabetics or diabetes sufferers. As we can see, some people have been commenting. So the first thing we should talk about actually is sponsorship, so that things like this can keep happening, meetings of this sort and meetings in real life moving forward. So we have our foundation's account number here on the screen. And because this meeting is going live and all that, it will be recorded and uploaded to our YouTube channel in the coming days, and also on Facebook, our Facebook channel. So our socials and all of that will also be included and all. So anyone that has, as we said, is able to make a donation or knows someone who will be able to make a donation to help the cause and all of that can make use of the account details we have here. So another thing, the second point is actually the additional resources that we have. We've conducted a training of this sort, but actually it was in real life, okay? 2 years ago, Dr. Agon mentioned it and all that in Luth. So following that training, we created a WhatsApp group to monitor post training gains and provide people with a resource where they could come on, okay, and get expert advice from our panel of podiatrists who are members of this WhatsApp group that could help. Like all these questions that we've had now and everything, if you could put them in the group and all that, they will be addressed with a similar level of expertise and alacrity that we've had, in real time and all that today. So the WhatsApp group, if you have an interest in joining the WhatsApp group, all you have to do is you send a text message to the phone number. The phone number is here on the screen that I've shared. I hope everyone can see it. So just send a text to that number and then we can now include you in the WhatsApp group. Beyond that, there's also the possibility of you getting, because I've already been asked in the comments, that the slides, how the slides become available to people who are interested in them. So all the slides that we used today, all the speakers and the facilitators used today that cover all the topics that they spoke on, the slides will be made available to you by email. So you just have to indicate your interest by sending us an email, okay, with your email address, of course, and then our emails are included underneath. It's just gentevinshf@gmail.com. So you send an email to that email and then we'll respond and then push the slides as an attachment or as attachments to your email box. And another advantage of having your email is that when opportunities present themselves, like anything that could be of benefit to you for joining this, for being a part of this meeting and an attendee of this meeting and anything that may be of benefit to you that we can make available to you, we'll have your contact and be able to reach you after now. So the third thing actually that we're going to mention is we want to do some signposting now. We want to talk about, like now we know that there are some people who are diabetes sufferers here on this meeting with us. And then there are also people that they know who would also need help. So of course, this goes to those kinds of people. Now, you can get diabetic help. You can get help for your diabetic foot problems and conundrums and the rest of that at the Lagos University Teaching Hospital in Diaraba, Lagos, the General Hospital in Ikorodu, Lagos. There's a diabetic unit there and all that. They also do foot examinations and foot care for diabetics. Then there's Victory Dogs Pharmacy at 11 Road, opposite 111 Road, Festac Town. That's also in Lagos. Then there's Rainbow Specialist Medical Center, Lekki, Phase 1. That's in Lagos as well. Then there's the Rainbow, hang on. Then there's also the Rainbow Diabetes Unit in Ikeja GRA, as well as, okay, outside of Lagos, we also have the Doing Healthcare Services Ibadan in Oyo State. I think Madam Yemisi spoke about that earlier on during her presentation. Then there's also the University of Benin Teaching Hospital in Benin, and then the Central Hospital in Benin, where we can get help for people with diabetic foot and competent advice and counseling and treatment as well. So on behalf of the Gintavines Board of Trustees and then Gintavines management, our perennial collaborators, our supporters, and our sponsors. We'll have to make special mention of Victory Drugs in Festac and Encapsulate Health Services as well. Okay, they've been perennial collaborators and sponsors, and they've made things like this, our meetings, possible. So we want to say a big thank you to these people, and a big thank you to everyone that joined and was able to attend this meeting. And we hope that everyone has a safe holiday, and we all transition into a safe and prosperous new year. Thank you very much.
Thank you very much. Thank you to everyone. Just a shout out to people who have joined from all over Nigeria, from Enugu, from Abuja, from Benin, from Lagos. There were some other states now. Thank you everyone for joining and taking your time. As we said, we will upload the video on our YouTube page. We will let you know if you do email us at our email address. We can let you know when it's uploaded, or you can just check back in a week. We should have uploaded the video if you want to watch again or share with other people. Sorry, John, could you stop sharing?
Okay.
Yeah.
Do that. Hang on.
So I just wanted. So if everyone for just 1 second could put their videos on, and so everyone can just say hello to everyone. If we're going to have like 1 or 2 minutes of networking. So if we put our videos on, and if you can unmute yourself, I've allowed you that you can unmute yourself, and we just say hello to each other. And see all the lovely faces that have been listening since, so what time did we start? 4 o'clock Nigerian time. I wanted to say 3 o'clock, but that's UK time. So thank you everyone for joining.
Hello, everyone.
All the panel is waving. Thank you very much.
Thank you very much.
Thank
Thank you.
Thank you for being
Very
there.
beautiful.
Thank you.
Thank you. Thank you very much.
Bye.
If you have any ideas
you.
of what we can cover
Thank
next
you.
time, please email us as well.
Okay.
Feel free to email us. We'll see what we can
Thank
do.
you. Thank you so much.
Thank you.
Thank you.
Bye-bye.
Bye.
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 Bye, Andre.
Bye.
Bye. Thank you.
Presentation was excellent.
Thank you. Thank you.
Thank you all.
Thank you very much.
Thank you, thank you, thank you, thank you. I appreciate you.
Thank you very much.
Thank you so much. Really enjoyed the lecture. We are
Thank
grateful.
you. Thank you for the
We are
feedback. Thank you.
much of this. All right.
Thank you.
See ya.
Thank you.
Okay, now. That's great. That's
Thank
very
you.
good indeed. Very, very good indeed. God bless you all.
Thank you very much.
Amen.
Amen. Amen. Thank you.
Auntie Kemi,
Yes,
how
ma.
you doing?
Thank you. Bye.
You're
Thank you.
welcome, ma. Bye-bye, ma.